Good afternoon and welcome to another episode. We are still celebrating or honoring World Fertility Day, and our next speaker is Dr. Sulaiman Heylen. He is from Cape Fertility Clinic, and they are out in Claremont in Cape Town. So thank you very much for joining, Dr. Heylen.
Thanks for inviting me, Lee, and it's always a pleasure to speak with you. Thank you
It's
so
a
much.
It's a pleasure. So, Dr. Heylen, we're talking about common causes of infertility. And one of our first questions we've got is what are the most common medical conditions that can lead to infertility, and how can I identify them?
Yeah, so we've got the male side and the female side. So if you look at infertility, it can be caused by the man or by the women. So it's about 50-50. From a male point of view, it's not always easy to know if there is infertility, yes or no. From a female point of view, it's sometimes easier to know. And there are four common causes of female infertility: endometriosis, polycystic ovarian syndrome, blocked fallopian tubes, and fibroids, growths of the uterus. So these are that is the majority of my job. There are other causes also, but these are the common causes. Now, how
Okay.
can you know? Okay, let's start by endometriosis. Endometriosis can give no symptoms, but a very common symptom for endometriosis is pelvic pain. Pain during menstruation, pain during the period, severe pain, not a little bit of pain, but severe pain, and other pain, like pain when you go to the bathroom, number one, number two, or pain during sexual intercourse, or chronic pelvic pain. So that's the other symptom. So you've got infertility and pelvic pain, then you know it's possible that you could have endometriosis. You have to check it out. Then we come to the second one, polycystic ovarian syndrome. How can you know that? Well, that also gives typical symptoms. And the most common symptom is that you have irregular periods. Instead of having your period every month, you have it every second month or every third month, or you bleed a little bit, then you stop, then you carry on, then it stays away for a while, then you bleed for 3 weeks. That's typical for polycystic ovarian syndrome. Not a regular period. You do not have your period every month. There are sometimes associated symptoms with polycystic ovaries: acne, abnormal hair growth, and weight gain. So these are the other ones. So if you say you have got irregular periods and you've got one of the other symptoms, then you can pretty sure there's a good chance that you will have polycystic ovarian syndrome. You have to check it out. Then the third one is fibroids. Fibroids, what is a fibroid? A fibroid is a benign growth of the uterus. And it can also cause sometimes no symptoms, but what can it cause? It can cause heavy periods. So the typical symptom of a fibroid is that you bleed excessively. So instead of having the normal flow that you used to have, you say, okay, every month it's getting more and more and more, and now it becomes really heavy. They say, okay, poof, I must change like every hour. I must wake up 3-4 times in the night. Sometimes associated with pain, but not always. So the most common symptom from fibroids is that excessive bleeding that you can experience. And the last one is the blocked fallopian tubes, and that's a problem because it's mostly silent. Blocked fallopian tube, in the majority of the cases, has got no symptoms, and it's caused by an infection in the majority of the cases in the past. So the fallopian tubes are blocked because of like in the majority of the cases, not always, but in the majority of the cases by sexual transmitted disease that was acquired long time ago, maybe 10 years ago, 15 years ago, you don't know. And it's asymptomatic, you feel nothing. And the initial infection is very often also asymptomatic. There's no symptoms. And then women come 10 years later, and then we pick it up to see the blocked fallopian tubes. It can also be caused by endometriosis or by previous surgery, but the most common cause of blocked fallopian tubes is an infection.
Okay.
That's from the female side. So especially, you must look at your period. If there is any irregularities with your period, or is excessive or very painful, could be that there is a fertility issue. From the male side, it's not so easy to know, and usually we only discover that there is a problem from the male side once we've done the sperm count. It usually comes as a surprise. But sometimes there are obvious clues. They say, okay, I've been operated when I was a boy on my testes, or at a bladder operation, or at an accident over there. Sports injury, and I had to go to the urologist. or at a trauma of the testis or the bladder, that we can say, okay, yes, okay, that okay, or an infection that he says, okay, a long time ago I had to go to the doctor because that's a severe infection of my testis and I had to take antibiotics. Or mumps is another common one. If you say I get mumps, then say, okay, these are like possible causes of male infertility. So then we say, okay, yes, then we definitely have to do a sperm count. So if you hear about one of these things and you think, maybe better to check my sperm.
Okay. Thank you very much, Doctor. Our next question is, what tests should I undergo to evaluate my ovarian reserve and egg quality?
Yeah. So before I go on to say about testes, I would like to explain first what is ovarian reserve. Huh?
Yeah.
A woman is born with a certain amount of eggs. A man makes millions of sperm cells every single day, so it's not fair, but that's what it is. Huh? So a woman is given an amount of eggs at birth. You must visualize it's an egg basket. And that egg basket becomes smaller every month. So if you measure the ovarian reserve, that we measure the amount of eggs in the body. How big is the basket? Is it still big or is it small? And there are two tests to do that. We can do that by doing an ultrasound, or we can do it by doing a blood test for something which is called AMH. So the ultrasound, that's the normal ultrasound that the gynecologist does. With a high resolution probe, we go to the ovaries and we see the little black things in the ovaries. It's called the antral follicles. And we count the antral follicles. And there are a lot of antral follicles and there are a lot of eggs in the body. Simple, go to the gynecologist, do a normal ultrasound. Quick, easy, painless examination. The other test is to do a blood test for AMH. AMH is something that is secreted by the follicle also. So it actually measures the same thing. So the follicle in the ovary is the structure that makes the egg. So we can see the follicle, the structure that makes the egg, or we can measure with a blood test how many of these follicles are there in the body. So the AMH test and the antral follicle count are two very reliable tests to see the ovarian reserve, which is a very useful test if you have to counsel a couple on fertility treatment options.
Okay, thank you.
Basically, how big is the basket? Is it small? Is it medium? Is it empty? Or is it very big? It doesn't say exactly how many eggs it is. It's just in relative terms. It's good or it's not so good.
Okay, thank you. And then our next question is, how do hormonal imbalances contribute to infertility, and what specific tests can assess my hormone levels?
Yeah. So we see that very often, that the woman comes in the office and say, I've been diagnosed with a hormonal imbalance. And I say, which one? And then I hear nothing anymore because it's not a diagnosis. That's like if you go and say, I've got a cough. That's also not a diagnosis. It's a description. So an hormonal imbalance is a description, but it needs to be explored further. So there are many different types of hormonal imbalances. I give an example. Diabetes is a hormonal imbalance. There's a problem with your insulin. You lack insulin. Okay, so not enough insulin, so you have to take sometimes insulin injections. So diabetes is a hormonal imbalance. Or it can be a thyroid problem, or it can be polycystic ovarian syndrome. And sometimes it's an imbalance between hormones. There is too much estrogen and too little progesterone. That's a typical one. Polycystic ovaries, too much estrogen, too little progesterone. That's what happens with polycystic ovaries. So the hormonal imbalance must be checked first. And sometimes there are symptoms, and that depends on what the cause of the hormonal imbalance is. So if it's polycystic ovarian syndrome, you've got the same symptoms as with polycystic ovarian syndrome. If it's a thyroid problem, you can pick up weight or you can lose weight. You can have problems with your heart. These are problems with thyroid. Diabetes, I mean, that has got his own problems. But the way to pick it up is just by testing the hormones. So we just send the person for a blood test. Women, men also, can also happen to men. Send for a blood test, check female hormone levels, male hormone levels, thyroid, prolactin, and AMH, and then the hormones that are coming from the pituitary gland and the thyroid. That are the most common ones. There are obviously other ones also, but these are the most common ones. It's easy, so we just do blood tests and we can pick up most of the hormonal problems. Maybe not call it imbalances, but hormonal problems. And then Once we have done the test, we can make a diagnosis. So
Okay.
you have this. You've got polycystic ovaries. So the cause of your hormonal imbalance is polycystic ovarian syndrome. It's the
Yeah.
same as you've got the cough, you got the doctor, you've got the cough. The cause of your cough can
Yes.
be that you just got a cold, but it can also be lung cancer. I
Yeah.
mean, very different that this.
Yeah.
So an hormonal imbalance is just a description and it must be explored further, because if you don't explore it further, then you cannot give a proper and appropriate response to that.
Yes, I completely understand that now because I think the term has been used a lot by everyone. Oh, it's just a hormone imbalance, hormone imbalance. But the way you're explaining it now, I'm really understanding it. Thank you.
You're welcome.
So the next question is, what tests can determine if there are structural issues such as blocked fallopian tubes or uterine abnormalities?
Yeah, so I think this is a very good question. And the answer to that question is changing over time. So in the past, we were pretty invasive with laparoscopy. And now we are less and less and less invasive. And we can do many procedures in the office now where we can have an extremely good idea about what's going on with the structure of the uterus and the fallopian tubes and the ovaries. So now we've got very high resolution transvaginal ultrasounds. The ultrasounds are becoming better and better and better, so we can see much better. And if you buy a new ultrasound, then you suddenly make new diagnoses. Wow, okay, I can see so well. So the transvaginal ultrasound that we have these days, the high resolution ultrasound, you can see very well the uterus and the ovaries.
Okay.
And with a good transvaginal ultrasound, you can see the ovaries as well as with a CT scan. Okay, so this is very good. So it's not necessary for most cases to do a CT scan. But you can't see the fallopian tubes. Fallopian tubes are not visible on an ultrasound. And therefore, we have to do a test where we insert dye inside the uterus and check if the fallopian tubes are open, yes or no. And there are two of them. The one is called the hysterosalpingogram. And you go to the radiology department and the radiologist insert the dye. And the other one is called the hyphosi. That's the one that's done by the gynecologist under ultrasound guidance. This hysterosalpingogram has got a bad name because it's sore. It is sore. It is painful. Some women say it's really very painful. The hyphosi, that's the newer test, it's not painful. Most people say actually I hardly feel anything,
Yeah.
because the contrast that we use is much gentler. And also, I mean, we don't want to brag, but it's done by the gynecologists, and the gynecologists are usually a bit more gentle than the radiologists.
Yeah.
So we do it ourselves at the fertility clinic, and the ultrasound guidance, and it's tested is as good as the hysterosalpingogram. So you've got the ultrasound and then the hyphosi to inject dye inside the fallopian tubes to see if they're blocked, yes or no. And then we've got the endoscopy, the laparoscopy and the hysteroscopy. So the hysteroscopy is that we look with the scope to the vagina inside your uterus. That's a very good technique that can be done under mild sedation or sometimes even without anesthetic to see what's going on the inside of the uterus, to check the lining and check for polyps, fibroids, and scar tissue inside of uterus. And the laparoscopy is that we go in from the top. And in the past, we did a lot of laparoscopies, which is a pretty invasive thing for diagnosis of infertility.
Yeah.
These days, it's not done anymore. We don't do diagnostic laparoscopies for infertility anymore because we've got other techniques now. And we only do laparoscopy if we would like to do something. So we do a laparoscopy if we say, okay, we would like to remove a fibroid, or we would like to do some tubal surgery or something like that, or we like to remove endometriosis, but not just a diagnostic laparoscopy for endometriosis. It's becoming a little bit old-fashioned just to do diagnostic laparoscopies. We now have got better techniques that we can pick up these things without doing a laparoscopy. So a good ultrasound is key. Then insertion of dye with hyphosi, maybe hysteroscopy. And we've got as a backup always the MRI and the CT scan. And the MRI is a very good non-invasive test to pick up difficult to diagnose diseases like endometriosis. So if 10 years ago, if I sent a patient to the radiologist and I say, please check for endometriosis, they said, what? Okay. And now they are so good at it to detecting endometriosis that they say, yes, okay, let's have a good look. And they're really good at it. So if we send a patient for an MRI scan to check for endometriosis. They can really see if it's there, yes or no.
Yeah.
So it's
Okay.
becoming much better and much less invasive, which is good.
Yes, yes, of course. Okay, the next question is, how is male fertility assessed and what tests should my partner consider undergoing?
Yeah, I always have that conversation with the couples when they come in my office. It's not fair, huh? Because the
Mm,
woman, I must do this and that, and I must scan, and I must inject the dye in the tubes, and I must do blood tests, and for the man, I just do a sperm count.
yeah,
And the sperm count, that's if we do a sperm count, if we check it with a microscope and it's fine, then it's fine.
yeah.
So then I've got the normal sperm count in my file. I can finally say the gentleman is okay. There's no problem with him.
Mm,
His story only starts when the sperm count is abnormal. Okay, so we say, please do a sperm count. If it's fine, it's fine. If it's not fine, then we have to do tests on the man.
yeah.
The same thing. Pants off, have a look at it, scan, do an ultrasound of the testes, send for some blood tests, and do some basic tests to see what is the underlying cause of the problem. Is there any disease detectable? Is there any infection, any hormonal issue, varicocele? These are the more common causes that we sometimes can pick up for a man. So for a man, we start with the sperm count, and if the sperm count is abnormal, we do additional tests. If the
Mm,
sperm count is normal, we just leave it.
yeah. Okay. Thank you very much. Our next question, second last question is, what role do lifestyle factors play in infertility? And are there specific assessments to evaluate my overall reproductive health?
Yeah, it's a big thing, huh? Lifestyle factors is a big thing. And it's both for male infertility as for female infertility
Yeah.
crucial. And we know that a healthy lifestyle does improve the chance of conceiving. So don't smoke, don't drink, exercise, and eat healthy.
Yeah.
That's it in a nutshell, huh?
Yeah.
Obviously a bit more complex than that. So if you look at, for instance, IVF, if
Mm,
you do IVF, then we always say it's a chance that it works and a chance that it doesn't work. If you
mm,
IVF on a woman who is obese, the
mm.
chance of success is reduced by 50%. It's like drastic, huh? That's
Yes,
like
yes.
amazing, huh? It's like a big difference. Huh? So therefore we can say, okay, lifestyle is very important. So we know that lifestyle has also an effect on sperm quality. Drugs, marijuana, alcohol, smoking, bad diet. What is the good diet? Huh? And now people are maybe going to shoot me for this, but very often see a low fat diet or a low carb diet or a low this or a low that. There is not one diet that we know for sure that helps. If you just cut off one group, so you take off that, you take off that. The
Mm.
one good diet that we know for sure is the Mediterranean diet that helps. Okay, and we know that for sure. It's proven in many studies, or diets that are similar to them, and that's not very sexy. But it's a diet based on fruits, legumes, and vegetables, lean protein and meat. Okay, and no processed food. Okay, no junk food. Okay, and that's the bottom line. So
Mm.
basically, a very healthy diet. And supplements very often are also said, okay, supplements, doctor, what must I take? But that's a very small part if you look at it from the lifestyle.
Yeah.
So you've got a healthy, balanced Mediterranean diet, and you do your exercise because we also know that exercise is beneficial.
Mm.
If you do moderate exercise, 30 minutes every day, that helps for fertility. Even if you're pregnant, it helps. And very often people think, oh, I'm trying to conceive, I must take it easy. No, it's not true. You must just do the opposite. Okay.
Mm.
You must be active because if you are in good health and if you do exercise, your chance of conceiving is better and your chance of pregnancy complications is reduced if you do 30 minutes per day moderate exercise. It's reduced, huh? It's not the same or it's lower. Huh? So that's amazing. We know now that for sure. In the past, we were always like, oh, you have to rest, you have to rest. Now we say, no, the opposite. You don't have to rest. Huh?
Mm.
Be honest, go for a walk. Huh? It's good for
Yeah.
you. It's good for your health. And it's good for your health. It's good for you if you would like to have a baby.
Yes.
And definitely stay away from drugs. Huh? and from alcohol, and from smoking and vaping, because sometimes people think vaping is better. Actually not. More and more evidence that vaping is also not good.
Yeah.
So stay away from all the toxic influences.
Yeah.
Sometimes also toxic influences in the environment, which is then mostly related to the job that certain people are doing, where they've got toxic products at the workplace. So try also to stay away from that if possible.
Okay. You mentioned now that you used to say that you have to lay down after treatment and stuff. I actually remember my aunt, she had IVF treatment. That is 40 years ago, almost 40 years ago. She had IVF treatment, and afterwards she had to go lay down. I remember laying in bed, and I'm watching like this lady just like treatment, and so things are completely different now. After the IVF treatment, you have to just go carry on normal.
Yeah, Leanne, I'm 61, huh? So been doing this for a while now, huh?
Wow.
So I remember when we started doing IVF in Belgium, just a story, huh?
Yes.
So then we did the embryo transfer, and then they brought the bed from maternity block. And then we put very carefully the patient in the bed. And then the patient went to the maternity block, and then we put a note on the bed. I still remember, do not shake.
Oh,
I'm serious. And the patient was not allowed to come out of bed for 24 hours.
wow.
So the nurses came and washed him in the bed and all these things. So, and
Yes.
that's because we didn't know. There was that.
Yes.
That's
My,
like
my
more than
auntie had,
30, more than 30 years ago. Huh?
wow, my auntie had to lay with her legs elevated. And I remember my granny making a scrambled egg because she must have protein. And that was from Dr. Stephanie van der Spey, is
Yeah.
the doctor that did her IVF that time, those years.
Yeah.
But
And 25 years ago, we would still do the embryo transfer, and the patient had to stay 4 hours in bed. And the bed was tilted like
yes.
that. And now we just do it and the patient goes home. And I'm going to
Yes.
tell you another story.
Mm,
My professor in Belgium also, he had a private practice.
yeah.
And in his private practice, he does an embryo transfer. So he takes the embryo transfer catheter, okay? And he's now about to do the embryo transfer. And there's a bomb scare in the building
Mm,
at that very moment.
wow.
So what he does, sticks the embryos in, takes the speculum out, grabs the hand of the patient, and they was on the second floor. They ran down the stairs together, okay? She got pregnant.
So it worked. So you just have to move off Tabby.
Yeah. So just saying, that it
Yeah.
doesn't matter too much. We at Cape Fertility, we say to the patient, now you have to rest for 5 minutes, just to,
Yeah.
just clear their
Mm,
mind and everything, and to just,
yeah.
5 minutes. But it
Okay.
doesn't help to rest after the embryo transfer.
Yeah. Yeah. Okay. Our very last question, Doctor, is how can genetic testing help identify potential causes of infertility, and should I consider it?
Well, yes and no. So genetic testing is usually not identifying causes of infertility.
Mm,
So if you come and say, okay, I've been trying to have a baby for 3 years, we're not going to do genetic testing because it's in the majority of the cases not helpful.
mm,
Obviously, genetic testing is very important, it's very useful, and you can do that. And something is called carrier testing.
mm,
Because all of us, we are carrier of genetic abnormalities. So you can do now these tests that they send samples away, and these genetic labs, they can test for over 400 different genetic abnormalities. And if you test me, I probably will be carrier of 1 or 2 or 3, I don't know, okay? But the majority of people, up to 70% of the people are carrier of one of the abnormalities. And so
mm,
if I test me, and you test your partner, and you try to have a baby, and you both are carrier of the same genetic abnormality, then you can have a child with a genetic problem.
yeah.
Because most of diseases, it's not a problem if you're a carrier. It's not a problem if the carrier is a problem, but if both are carrier of the same disease, okay,
Mm,
which is not likely, but it can happen, huh? Okay,
yeah.
then you can have a child with a genetic abnormality. So that's one reason why sometimes genetic tests are done for carrier testing.
Yeah.
And then sometimes also we do genetic testing because we think there is something that rings a bell with us. Huh? We see a person with, for instance, early menopause. We say, okay, this can be a genetic abnormality, can be what we call a Turner syndrome. Or we see a man with sperm problems. We think about Klinefelter syndrome. So we think sometimes about specific genetic abnormalities. We say, okay, we have to do genetic abnormalities.
Mm,
And then in couples with recurrent pregnancy loss, with repeated miscarriages, there can be something which is called a translocation, that a piece of a chromosome jumps to another chromosome. Can happen to both males and females. And that can also sometimes be a cause of recurrent miscarriages. So a couple comes to us and say, okay, I've had 5 miscarriages already, and all were between 8 and 10 weeks. And I think, could be that there is a genetic issue. So let's do genetic tests. Yeah. So it's not part of the routine fertility testing, but very often we do it because we've got a specific reason. And then there is the other thing, that's the carrier testing, that maybe in the future is going to become more and more and more common, just to see if there is an increased risk of having a child with a specific abnormality.
Okay. Thank you very much, Doctor. I really appreciate your time. And
You're
I know
welcome,
you
yeah.
had to run from doing some to working at the hospital and running to do this. So I really appreciate
I
your
was
time.
just doing some reproductive surgery to try to fix some things, yeah.
Thank you very much. Have a,
Now you're welcome, yeah.
yeah, thank you very much for this, and have a lovely day further. Thanks, Doctor.
You too. Yeah.
Dr. Sulaiman Heylen is at Cape Fertility. If you have any questions, you'd like to get hold of him, like to make a booking with him, please do so. You can contact capefertility.co.za, and you can also email Dr. Heylen. I will leave the details in the caption of this talk. Thank you very much, everyone. Have a lovely day further. Bye, Dr. Heylen.
Bye, Leanne. Thank